So today we gathered here to disseminate the results of a series of studies that we have been doing, the latest of which is looking at the genetics of post-traumatic stress disorder in people of African ancestry. But this is the latest in a chain of studies that began more than 10 years ago, looking at the genetics of psychiatric conditions in Africa. So in this particular study, we recruited participants, 4,000 participants from all over Nairobi. And in those participants, we interviewed them using standardized instruments that were looking at exposure to trauma, as well as occurrence of post-traumatic stress disorder and other conditions, including depression, anxiety, substance use, and even physical conditions. The aim of that was to try and correlate the exposure to trauma to the occurrence of those conditions. And the second thing that we did with these study participants is that we collected saliva samples from which we extracted DNA that we are currently analyzing. And the goal of doing that, again, is to try and correlate different signatures in the genetic material of the individuals with the occurrence of post-traumatic stress disorder and with the propensity to be exposed to certain kinds of trauma. So that is what we came to disseminate today. Our findings are still preliminary, but they have shown a very high rate of exposure to traumatic events in this city. They have also shown a very high burden of post-traumatic stress disorder among the people in Nairobi. And we are still looking at the factors associated with this. In our recruitment strategy, we had, people, men and women. We had people of all the ages, and this is shown in the findings that we have. We've shown marginally higher rates of post-traumatic stress disorder among the women, significantly higher among the young people because they were the larger proportion of our study population. And we are still analyzing the DNA material, and when these results are ready, then we will be able to do the correlations that are necessary and share those results with Kenyans and with Africans. One of the important lessons that we have learned from this work is that in clinical settings where we recruited our patients from hospitals, from Aga Khan University Hospital, from Mbagathi, and from Mama Lucy Hospital, one of the things that we learned from this is that in the clinical setting, we need to start practicing trauma-informed care because a huge proportion of our patients are coming in after exposure to trauma, but that is not what they are coming to the hospital for. And we need to set up our environments so that they are not exacerbating the effects of that trauma, and so that there are healing spaces where people can get help, including for the effects of the trauma exposure that they have had. So this is one of the most important lessons. But the other important thing that we have done here is capacity development. From this series of studies, we have more than 10 people who have gotten, PhDs or masters or fellowships in research training. We have a large team of research assistants who have also undergone training, and they have acquired invaluable experience in conducting research of this type. And we have published several papers from that series of studies that describe the study population, that describe some of the phenotypes, some of the things that we are seeing from our questionnaires. We will continue the capacity development. We will continue to publish out of this work after we've completed the analysis, and we will continue applying what we have learned in care and in education, in psychiatry and in mental health.
Daktari, do you have some of the unique causes of PTSD among women?
So, as I said earlier, a large proportion of Kenyans are exposed to trauma, and there are very many different types of trauma that people are exposed to, ranging from physical violence, sexual violence, death of loved ones, accidents, and so on and so forth. These are happening all around us. A proportion of people exposed to those traumas develop post-traumatic stress disorder. And the reason why this happens, we are still studying, but some of that is associated with gender. So women, after certain types of trauma, women are more likely to get post-traumatic stress disorder. For instance, when we're talking about sexual violence, the risks of trauma after sexual violence are very high. And as you know, in this environment, women are still exposed to huge risks of sexual violence. After physical assault, the risk is a little lower than that, but it is present. And again, women are exposed to a lot of physical assault in our setting, especially in domestic settings with intimate partner violence and stuff like that. But as for the other traumas like road accidents, many of us are exposed to those. Flooding, displacement, all those are potential causes of trauma exposures.
And
Yeah.
I'm just curious, what criteria did you use to select the 3 sub-counties from Nairobi County?
We selected them based on the facilities where we were basing the study. So the 3 facilities were Aga Khan University Hospital, Mama Lucy Hospital, and Bagadi. And so we also, when we decided to go to the community, we selected the community around those facilities because anybody we found who had a problem, we would refer them to that facility. And so that is why we focused on the facilities, on the communities around the facilities that we were based in. Yeah. Yeah, so as part of this study, we piloted an intervention in a small subset of the population that we studied, about 30 participants who had high levels of post-traumatic stress disorder. We piloted an intervention that uses an app, a mobile app. It's called Stair Coach. We are again still analyzing the results, but we were looking at acceptability and feasibility of implementing that in our setting because it had been tried in the US. And the findings from our study, preliminary findings at the moment, are that yes, it is feasible because we were able to recruit the number that we wanted, which was 30. And it looks acceptable because 25 out of those 30 persisted for the 6-month period that we carried out this study. So we find that people, and the people engaged with the app. And preliminary results also show symptoms reduced in the course of that intervention. So this gives us hope that if we expand this to a larger population, we are probably going to get better results. It is different because this one is facilitated by a trained facilitator. So other apps, you just go and do it on your own. And what we have shown in those other studies with those other apps is that people might begin and sometimes they do only one session and that's it. Or people might do a few sessions and then they're done. And then we don't evaluate the impact of those interventions. But with this one, there is a trained person who is in contact with the patient at the beginning, and then even 2 weeks after that, they contact them on phone, and then they come in person after maybe 4 weeks or so, and they have contact and they discuss what they are going through. They discuss how they are applying the app. They discuss any challenges they are getting and what support they might require. So this is ongoing. This engagement is what keeps people on, and we think maybe that's part of the treatment effect.
Yeah, what are some of the challenges you face?
So because this is new research, most people, nobody has done work that is trying to look at post-traumatic stress disorder, trauma exposure, and the genetics of it in this part of the world. So explaining to people what we are trying to do, going through all the regulatory processes, it was a long journey. But it was necessary because it is important for people to know what we are trying to do and for people to understand it so that when they're giving consent and saying, I'm happy to participate, it is truly informed consent. So, but it took quite a bit of time planning, preparing for it, engaging the community, engaging the county, engaging the national government, and getting buy-in from all the stakeholders. That was, I think, one of the biggest phases. But once that was done, we had support from the county, we had support from the national government, we had community health promoters working with us to identify potential participants, and it went very smoothly, as you might have heard during the meeting today. Yeah.
And also the issue of privacy. A lot of people who might even wish to participate in this research, they might want to know their data.
Yeah.
Privacy. How can you assure them that?
So all the data that is analyzed is de-identified. So we can't tell who specifically gave us that data. It is separated from the identifiable information that is used for consenting. But once we start analysis, we can't trace it back to the individual. And the data is kept by us very securely, and nobody has access to it except us and except for research purposes only. Nobody can access it for any other use because that is how we set up the protocol. Yeah. Yeah.